I think one thing I want you to remember is that antipyretic associated hypotension is a thing. It happens. It doesn't happen to everybody, but you need to be aware that potentially that this could happen to your patient and be prepared to respond to it. The drugs that we treat, even very basic benign drugs that we've had since the 1950s, they don't always behave the same way in critically ill patients. So I think we have to be curious about how these drugs, like acetaminophen, impact our patients and explore that further. The other thing is, if there's one thing I wish the entire world would just stop doing, is that don't externally cool an awake patient and make them feel uncomfortable and bring down their temperature and think that you're improving their metabolic demand, because you're making it so much worse for them, and it's incredibly uncomfortable. Comfort is king, and if you really need to bring down their temperature with external cooling, you have to sedate them first. And the third thing is, when you have a patient with a fever, there is no right or wrong answer. You really need to take a look at the patient in front of you. You need to be curious, and you need to kind of weigh the costs and benefits for this patient at this time, at this stage in their illness, and then make that decision.